Hi, everyone. My name is Zahir Basrai, and I'm an EM physician in Los Angeles. I did my residency training at Harbor UCLA and wanted to share some tips on how to crush your EM sub-I. I am joined by Manuel Celedon, who will give you a little intro.
You already introduced me, but I'll reintroduce myself. My name is Manuel Celedon. I also am an EM physician in the LA area, and I trained at Harbor with Zahir. He was actually my senior resident when I was an intern. But we're the same age, so I'm just behind.
All right, so let's go ahead and get started. What we wanted to do was to help med students understand the thought process of how to manage all the chaos that occurs in the emergency department. It can be really easy for a med student to get lost, and as a result, that makes it really hard for them to shine during their EM sub-I. So the first thing we'll talk about is just general EM priorities. This is how you want to prioritize all the activities and patients that you see in the emergency department. So number one is the sickest patients first. No matter what, it's your responsibility to work and treat sick patients. After that is discharges. So the moment you can discharge a patient, you should discharge them. This is important because when you hit that discharge button on the computer, it activates a cascade of events. For example, the patient gets the aftercare instructions, they get escorted out of the department, someone needs to come and clean the bed, and then a new patient has to come in. So by activating discharges early, you are able to help with the efficiency of the department, and that will be recognized by the people that are evaluating you. The third thing is to pick up new patients. So after you're done seeing all the sick patients and putting in the discharges, you want to try and pick up any new patient that's in the department. And after you see those new patients, you want to reassess your old patients. So because you will be performing parallel processing, you will have a list of patients that are all being worked up at the same time. So it's important periodically to go back and to make sure that you reassess them and that you ensure that all of their labs, imaging treatments are all being performed so that you can efficiently discharge them. And finally, the last priority, which is oftentimes the most stressful one, especially for med students, interns, is writing notes. But really, this should be prioritized last. It's something that has to be done, but you don't want to sacrifice seeing a patient who's super sick because you're writing a note. When you talk about discharges, I just want to define what a discharge is. For us, it's defined as being discharged home, being admitted to the hospital, or having a consultation place. Yeah.
Yeah, no. So I think it's really important to establish this framework from which to kind of approach how to approach emergency medicine. And if you keep this in the back of your mind, you'll always kind of have a, a way to anchor yourself during your shift, right? It's most important to see the sick patients. You're an emergency medicine doctor. That's the most important thing, taking care of sick patients. And then, as Zahir said, dispositions, whether that be an admission or a discharge, opens up an ED bed, and ED beds are worth their weight in gold. So if you have an open ED bed, that means there's no patient waiting in the waiting room with an unknown disease that's been undiagnosed, right? You have a patient in a bed where you can actually evaluate them. So it's really, really important if your senior resident or attending tells you to discharge that patient, that unless there's a really, really sick patient, you need to prioritize that over anything else, because that'll open up more beds and get the department moving. And then other thing I'll say about writing notes is that, it'll feel like it's a lifetime to take 10 minutes away from your shift to just sit down and write notes. But if you're try as much as you can when you're on a shift, if things are kind of calming down, to just, put yourself in a sensory deprivation type chamber, block everything out, and then just sit down for 10 minutes and bang out as many notes as you can, because that'll help you end on time and not have to stay 2 hours later writing your notes at the end of your shift.
Cool. So the next thing we wanted to talk about is the EM internal clock. So in order to efficiently work in the department, you should set timeframes that help organize how quickly you need to evaluate patients and dispo them. So for example, if the patient is super sick, meaning they need to be intubated, get a central line, have advanced resuscitative measures performed, you want this patient admitted in 2 hours. And that's a reasonable time frame to begin to get some of the data back from your labs and your imaging and to have a working differential and diagnosis when you call up that mission. If the patient's not super sick, so it's someone who doesn't need any additional lab workup, maybe just needs a dose of Tylenol, or if even that, then that patient shouldn't occupy more than 2 hours in your department. Um, the middle ground are patients who need more of a workup. So maybe they need CT imaging of their abdomen. And those patients you can allocate 4 hours to, but you definitely don't want to spend more than 4 hours on those patients. I did part of my residency training at a program where after 4 hours, the EDIS or the ED tracking board, it's the board that has the list of all the patients, that would turn the patient's name red when it surpassed that 4 hour mark. So if you had a bunch of red patients on your board, your attending would be like, what the hell are you doing? So it is one of those things that everyone is kind of looking at. So as a sub-I, it's really important that you try to be efficient and to get patients in and out within 4 hours. And try to figure out what causes delays in your hospital on day one. The moment you walk into the ED on your first day of your sub-I, ask the other residents, what are things that slow you down? Is it getting UAs? Is it getting the patient down to radiology? Is it getting the labs drawn and sent to the laboratory? And figuring out where those stop gaps are will allow you to be more efficient because you can anticipate that those things will slow you down and get those processes in place. And finally, if it takes you more than 4 hours to see a patient and dispo them, at the end of your shift, you should reflect as to why it took you so long to dispo that patient. Was it that the patient's pain was inadequately treated or something along those lines? If it was a nursing issue, maybe you need to improve your ability to communicate with nurses or your techs. So it's good to develop that skill early on because it's something that you'll carry forth throughout the rest of your training. And the more efficient you are in residency, the better, the easier it is. And especially as a sub-I, the more efficient you are, the more people will notice you.
Yeah, I mean, we're not expecting you on day one of your sub-I to be able to do all these things, but it does help separate you from the rest of the class if you're at least kind of working at building these into your workflow. I think the 2 hour and 4 hour rules are good ways to keep you honest while you're on a shift. They're many reminders to try to develop dispositions, right? So if you're sitting on this, intubated patient with a central line, and you're in, it's been an hour and a half, and you haven't really dispositioned them, you should be starting to think about like, this patient's not going home, right? They're staying in the hospital. So what am I holding on to them still for, right? Like I should be trying to move them upstairs because the disposition is pretty much set. And so it's a good reminder of trying to figure out what barriers you have to dispositioning the patient and then trying to solve those barriers or trying to overcome those barriers as you're going on in your shift. And you have up to 2 hours. It doesn't mean that you keep a toe pain in a room for 2 hours just because there's a 2 hour rule. No, like toe pains should be in the room no longer than, 10, 15 minutes, right? So you have up to that amount of time, but you really shouldn't be passing that amount of time. So like, if it's been, I guess a better example would have been if you have an intubated and a patient with a central line and it's been 3 hours and you haven't dispoed them. I think the big question is why haven't you dispoed them, right? It's past the 2 hour mark. The other thing is, the classic delays in hospitals are collecting any sort of specimen that nobody wants to touch, right? So that's urine and poop, right? So identifying that whenever you order that, there's going to be probably delays unless you're kind of micromanaging them, that specimen actually being collected. CT imaging as well as X-rays is one of the other bottlenecks, depending on how well the hospital is run and how well resourced they are. It may be something that you need to wheel the patient over to CT, or maybe you need to, go over to the X-ray tech area and have them come in and bring the portable monitor to get the portable chest X-ray. And then IV access is another thing that sometimes happens in under-resourced hospitals where, the nurse might not even tell you that the reason the labs haven't been drawn on the patient is because they weren't able to get an IV. So just kind of, following up with your staff as to whether or not the things that you order are getting done is going to be important. Because just because you put them in the electronic medical record doesn't mean that it automatically happens.
Yeah, and one of the things that's important is to also create the time triggers while you see patients. So if a patient appears on the board and you get assigned to that patient, you should be in and out of that room in 20 minutes. You should try to have orders in within 30 minutes. If after an hour labs aren't being processed, you should be asking yourself, well, how come they're not processed? There's probably something wrong. Maybe the nurse can get IV access. Maybe the lab is sitting on it. There's some point in that chain that you need to address to try and get all the information through. And there's nothing better than a medical student who is able to help push the patient through the process. And that's really what'll stand out to your senior residents and your attendings is your ability to stay on top of everything and to be able to get these patients from their bed to a dispo either upstairs or out the door. So this also goes along with the principles of parallel processing. So it's tough. The emergency department is full of distractions. And so what'll happen is you'll have 15, 20, 100 things on your plate that you need to do. And then a nurse will come and ask you for another task. And it's going to feel overwhelming as you have more and more things that are just piled on you. And it's going to feel like you're unable to get any one thing done. But it's important to develop this framework, as Manny referred to earlier, that'll help you stay focused on the tasks that are important. So every time that I go see a patient and come back to my workstation, I always run my board. And what that means is I go through each patient that I'm assigned to and I think, what are the things that I need to get back in order for me to dispo this patient? By doing that, I'm constantly working towards that goal of disposition, and I ensure that all of my patients are moving towards that direction. So especially as a sub-I, hopefully you have at most 2 or 3 patients on your list that you're trying to get through. Always run in your mind, what do I need to get these 3 patients out the door? What am I waiting for? What can I try to speed up? And if you do that, that'll allow all of your patients to exit the department, hopefully within that 4-hour window that we talked about. So always anticipate the rate limiting step, like we mentioned in the prior slide. And one other thing we'll mention is don't wait to do procedures. So for example, if a patient presents with right upper quadrant abdominal pain, before you even go to the room, grab your ultrasound machine, take it in, do your exam, talk to the patient, and then try to do an ultrasound, even if you don't know how to do it. But at least you have that information to present to your attending, and it shows that you're trying to multitask. And when they come and see the patient, the ultrasound will be there.
Yeah, I mean, I think to piggyback on that is the concept of bundling everything up front, or as much as you can up front, so that you're minimizing the going back and forth into the patient's room. I think that's especially true in the COVID era. But the ED is a little bit different than what you maybe have been used to. It's we try to do pretty much everything up front, right? We don't just get one test and then depending on what that test shows, 2 hours later we get another test, and then 2 hours later we get some other test. It's as much as you can do it all up front. And part of that is not waiting to do the procedures at the end, because what will happen is they'll just hang over you the entire shift, and then you'll always keep on punting it forward because you have other things to do, and and you're going to feel like it's going to slow you down to do a procedure. So again, try to do that and get that off your plate as soon as you can. And the ED is a very chaotic area, and you have to, as much as you can, be organized and have a workflow in place for you to be successful. And part of that workflow includes running the board internally. So in your own head, you should be always running your list of patients and going through each one of them and asking yourself, do I have a dispo? because you can have an unlimited number of patients on your list and not be stressed out if every single one of those patients has a dispo, right? Because once you have a dispo, you know what you're doing with that patient, and it's not, you know, the stress comes from not knowing what you're doing with the patient that you have, and then you start getting more and more patients on top of that that you don't know what you're doing with, and all of a sudden you have a list of, you know, 10 patients where you're like, I have no idea what I'm doing, and I'm about to sign out because my shift ends in an hour, and nobody likes to get 10 sign outs, right? And so running the list internally, but also doing it externally with your attending and your resident every couple of hours to make sure you're on the right track, is going to be important as well.
So just to put this in practice, basically you'll sign up for patient 1 and 2, assess whether or not which one's sicker, go see that patient first. Remember, you want to try and be out of the room for each patient in 20 minutes. You'll come back to your workstation, place orders for patients 1 and 2, and then sign up for patients 3 and 4. Notice at this point, we're not mentioning doing notes. You want to try and sign up for patients 3 and 4, see them, put in orders, and then return back to your desk. At that point, you can then follow up on the results of patients 1 and 2 and see if they're ready for dispo. And if they are, you can get them out of the department. After you're done putting in your dispositions, you can then sign up for patients 5 and 6 if there are more patients to see. Or if you have a second, you can write the notes for patients 1 and 2. And again, this could be one of those moments where you set your timer and you spend 10 minutes and just pound out the notes. But this is a really nice flow that is oftentimes not achieved just because while you're in it, you'll get a trauma or a code or some other patient that'll completely obliterate this flow. But this is what is important for R2s and R3s as they begin to see more and more patients to figure out this flow. So understanding this as a sub-I, and if you're able to put this into practice even with one patient at a time, it'll allow you to be very efficient, and that'll of course get picked up during your rotation.
Yeah, no, I think part of the this framework is understanding that it's something you're going to work up to. It's not something that you're expected to know from day one, and knowing that you may not have the chance, depending on how many patients there are, to be able to do 2 at a time, but having the capacity to flex up to that is important, and that all comes with practice. You know, if you're picking up patients 1 and patients 2, you want to make sure that you're triaging that appropriately, and how you triage them. Just because you signed up for patient 1 first doesn't mean you go see them first. You want to make sure that you assess that they have no high risk chief complaint, right? So make sure that, you know, any sort of vital sign abnormality on a chief complaint, that's something that you go immediately to the bedside to assess, versus patients that have, you know, like something like toe pain, right? So if you signed up for patient 1 and they have toe pain and patient 2 has, you know, bradycardia, just because you signed up for patient 2 second doesn't mean you go see them second. You go see patient 2 first, and then you go see patient 1, right? So being able to triage that is important.
Yeah. So as we talked about, this is perfect in an ideal situation, but of course, this flow is going to get obliterated. And that'll be because there'll be a trauma or a code that'll come in that'll suddenly pull you to it. Now, it's very easy, especially as a med student, to end up in the peanut gallery and not in the thick of the action. So it's really important that during your traumas and your codes, you know what to do to actually become involved in them. And if you're able to be involved in your traumas and codes, you will be remembered by your senior residents and by your attendings. So there are only a couple of things that I think a med student can do, but will allow you to actually be in the thick of it. And that would be cutting the patient's clothes off. So the moment they're transferred from the gurney to the bed, you should be there with trauma shears and getting the clothes off the patient. The second thing would be to be a pulse checker. So if the patient is in cardiac arrest, have your hand on the femoral pulse at all times during CPR, so you can feel the pulse, and then during pulse checks, people will look at you to see whether or not you still feel a pulse. And if you don't, then you'll be able to report that and they can begin CPR again. And then finally, you should be the CPR machine. So if you see a patient needs CPR, be sure to get in position to be able to relieve whoever is doing it at that time. And then that way you can go ahead and ensure that you're, again, so that's the really, there are a bunch of other things you can do, but I think codes and traumas can be quite scary. So what you want to do is simplify what you're thinking about when you are going through this. So if you think about cutting clothes off, pulse check, and CPR machine, and those are the only three things that you think of, you'll definitely have an opportunity to be part of the code or the trauma and to be able to be able to stand out from stand out in the eyes of your attending and your senior resident. Cool. So presentations are the other way that you will really stand out. It's really important that you have concise and precise presentations. You don't want a lot of extraneous information in your HPI. You want it to be very focused. Now, this is contrary to what you're taught in med school, where you're rewarded if you remember the name and document the name of the patient's cat. In this case, you want to streamline everything. So in order to do that, your HPI should be focused around your critical differential diagnosis, which is developed by understanding what the patient's chief complaint is. So if you start writing your HPI based off of the critical differential, you'll remember a lot of things that are oftentimes forgotten. For example, if a patient has chest pain, you'll actually remember to report whether or not they've been immobilized or had recent travel, because PE will be on your differential. Um, when you present the physical exam, you'll actually remember for a shortness of breath patient to look to see if they have lower extremity edema or JVD, to see if they have CHF. So you don't need to report everything the way that you were taught in med school, but rather you want to make sure that you're focused on the critical differential. Now, this is kind of a secret, or not really a secret, but when you are presenting, your audience is essentially developing a differential in their mind. And what you're leading them through is whether or not they need to reorganize that differential list during the presentation. So that's why it's of critical importance that you organize your HPI based off of your critical differential. And then finally, make sure that you always have you end your presentation with labs, imaging, treatment, and dispo, especially treatment. You want to make sure that you know exactly what interventions you perform, whether that's IV fluids, whether it's pain control, nausea meds, antibiotics, diuresis, anything. You got to make sure that you have a treatment plan that you articulate and emphasize, because again, that's next level. That's more R1 or 2 level training. And so if you can demonstrate that you're at that level as a sub-I, you'll definitely stand out. Cool. And, to develop your differential and your treatment plan, we highly recommend wickham.org. That's WIKEM.org. It's very streamlined, and like I would say most internal medicine texts and surgery texts don't really talk about the disposition plan, but EM texts, including Wickham, all have disposition sections. So as Manny was saying, you can articulate your disposition using evidence-based medicine that's all listed in Wickham. And that way you sound as if your plan is much more definitive than, I don't know, I think this patient's fine, they can go home. So definitely know your resources so that when you step up to present, you can knock it out of the park. And then last thing is like note writing. We talked about how note writing sucks, but it is important. So if you feel like you're falling behind, set that timer for 10 minutes, go into your isolation chamber and just do as much as you can. The longest part of your note should be your MDM. And again, this is contrary to what you're taught in med school. The history is important, but again, it should be very focused. The who, what, when, where, why of the presentation, as well as the pertinent positives and negatives for the critical differential. The medical decision making is where you want to spend most of your time, and that's going to be where you articulate the reasons why you either worked up or ruled out the diagnoses that could kill a patient. And for example, if you were to have a chest pain patient, you would use what Manny said in the prior slide about how you ruled out ACS after you get all those results back. So again, it's probably, it would be a good thing that before your rotations begin, you maybe construct what your MDM could look like for chest pain, shortness of breath, abdominal pain, weakness, dizziness, headache, back pain, because then what you can do is use that same medical decision making where you're ruling out all of these critical differentials. And the reason why the MDM is so important is also for medical legal purposes. If you are ever called into a medical legal case in your career, the lawyers aren't going to be looking at your note and again looking for the name of the cat, the patient's cat, right? They're going to be looking to see if you considered the life-threatening condition that killed the patient, and if you considered that in your MDM. And if you didn't, that's when they will peg you as being negligent. So even if you did think about it, if it's not documented, they will have considered it something that you missed that led to an adverse outcome. So this is, again, more transitioning from that MS4 role into intern year, but that's what we want to give you a glimpse of so that you can perform as a true intern during your sub-I. And that's it. I mean, the last and most important piece of advice is have fun, be enthusiastic, show up to each shift ready to go, and best of luck. Yeah, and that's what your senior residents and your attendings will pay attention to and remember you as. It's a lot easier for them to remember the person who comes in who's positive and enthusiastic every shift. And that stays with them a lot more than the person who comes in who is dragging their feet and not someone who is self-motivated. So get in there. And, yeah, that's true. But yeah, we wish you all best of luck, and we hope that this really helps you not only for the sub-I, but as you begin your internships and the rest of your career.